Evan?
Invalid entry.
Thank you, Zoe. Welcome, everyone, to today's webinar on continuity of care for suicide prevention. We're really excited to have all of you joining us today, and we're hoping that it will be an interesting and fruitful time together. So we have a few items on the agenda. First of all, I just introduced myself, and you've also been hearing from Smita Varia, another prevention specialist here at SPRC, who has been welcoming all of us. We'll hear some more from her later. So today we're going to do a bit of an overview of continuity of care and look at some key considerations. We're also going to hear from some of your peers in the field as to some of their strategies that they have been using and how those have been working. And then, as you may have heard, we're going to go into breakout rooms, a tribal and a state breakout room. So before we really get started, I'm going to turn it over to Zoe Baptista, who's going to give an overview of the technology for today's meeting.
Hi, everyone. Thanks for joining us. If you're having any technical problems joining this webinar, please call SPRC at 617-618-2380, or you could call Adobe Connect at 1-800-422-3623. These numbers are going to be in the bottom left-hand corner of your screen. If you have any questions at any time during the webinar, everyone's going to be muted, but you can use the chat box, the group chat on the left-hand side of your screen to send us your questions. You can also use the chat box, actually everyone should, and I see most people have, to please let us know if you are state, would you like to be in the state or the tribal breakout room, which will be coming in a little while. So just put an S or T after your name if you haven't done so already. And finally, you can make your presentation screen a little bit larger if you'd like to see it bigger by clicking on the 4 arrows, each going in an opposite direction, in the upper right-hand corner of this technical orientation slide. It's right on the pod there. So if you click on that, your screen will get larger, and if you click on it again, it'll go back to the size it is now. Thanks so much. Julie?
Thanks very much, Zoe. So I'm going to start off today's webinar with a story and my beautiful, beautiful, talented artwork here on the screen. So at Lincoln Middle School, a teacher has a concern about something a student wrote as part of their English assignment. The teacher refers the student to the school counselor. The school counselor, after talking with the student a little bit more, calls mobile crisis counselor. And mobile crisis counselor determines, yes, the student is at high risk, gets their parent involved, and gets the student into suicide-specific mental health treatment. So this is the ideal scenario. And what we're going to be talking about today, and what I'd like to hear from you all, is in scenarios like this, what is needed in order to make sure that the chain of care that I just described actually happens and that it happens well. So let's start things off with this scenario, and I'm curious to hear from you all. In this case of going from the school to mobile crisis to outpatient mental health, what are some steps that could help ensure that these transitions happen and that they happen well? I'm curious, to hear some ideas from the audience. So go ahead and chat into the chat box your ideas about what some steps might be to help this process. I see some folks are typing into the chat box. Great. So Jan from Kentucky wrote MOUs and MOAs between the entities. Wonderful. And Colby Coughlin typed, the counselor has a resource list available at their fingertips with up-to-date contact. Wonderful. Relationship building, sharing of resources. Thanks, Marissa. So in that relationship building, some of those things might include that the school has a specific arrangement with the mobile crisis and they understand what the mobile crisis needs from the school and how it operates in order to really make that an effective transition. Jeff is talking about using a statewide hotline to help the school triage students to appropriate care. It's wonderful. And having wraparound services and follow-up for a year. Great. And we're going to also in the breakout rooms get even a little bit more into what various folks are doing. Wonderful. Candace shared that the parents are involved with the process, and that's also really important. The with mobile crisis and the school counselor, hopefully will be able to explain things to the parents in a way that they really get it. Becky shared that mobile crisis unit is actually mobile. So the parent is presumed that they will take the youth in for assessment, but it also might be how can you actually really help support the parent to get the student in for assessment. Kim Walton said having school-based counselors from the same hospital, wonderful. So these are really great steps and a great starting point for how this could help happen. Some other pieces might be that mobile crisis would create a safety plan with the students and parents to talk about means restriction. Perhaps they are able to send their encounter notes from the mobile crisis to the mental health provider, from the school to the mobile crisis, and they understand, what the HIPAA ramifications are involved with that, and that there's follow-up, like Jeff said, to make sure that the appointment was actually kept, or troubleshooting barriers. So this is what we're going to be talking about on today's webinar. How can we make sure that these chains of care happen in different settings? The term continuity of care has probably been thrown around a lot recently, so I wanted to just define it to get us started. So continuity of care, which is also called care linkages or care transitions, is maintained when one care provider links to another and the transition is smooth and uninterrupted for the patient, with the essential clinical information being also transition from one care setting to the next. And this definition comes from the paper that David Nesper wrote with us, SPRC, and the American Association of Suicidology, called Continuity of Care. And he also notes that this is really essential whenever care is fragmented, meaning that it doesn't all take place in the same with the same person, really. In the paper that he wrote, was looking primarily at clinical settings, but these principles can also apply to non-clinical settings, such as cultural programs, juvenile justice, foster care, etc. So continuity of care is a concept. It's not any one specific intervention. You can't look in the best practices registry and find the program called continuity of care because there is no one single program. It's an idea that has multiple ways of addressing it. Continuity of care takes place in between someone being identified as at high risk and their ongoing care. So it's not screening itself. It's not gatekeeper conversations itself. It's what happens after somebody screens positive or gatekeeper raises a concern or some other means of identification and the ongoing or aftercare in order to ensure that they actually get to that second step. So during ongoing care, somebody might be periodically reassessed to make sure that the kind of care that we're hoping that they get is still appropriate for their level of need. So reassessment might be part of it, but screening itself is kind of the pre-continuity of care. Continuity of care may be a sort of one-step process, or it may have multiple pieces of a chain. So first between identification and stabilization, so like between a school and an emergency department, and then between stabilization and ongoing care. So in that example, between the emergency department and outpatient mental health. For simplicity, we're going to look at just the one-step process to look at some of the different strategies. So the identification settings are on the left, things like primary care, foster care, emergency departments, and the aftercare or ongoing care settings are on the right. And in the middle are the continuity of care strategies. And this is a tribal example, and you all should have received this or something similar as a handout that was in the webinar Outlook invitation. And this is a state example. They're very similar. They just have a couple of little tweaks that are different. To talk a little bit more briefly about the strategies in the middle, I'm going to invite my colleague Lisa Kaposha to come on and talk a little bit about those. And then later in the webinar, we're actually going to go into some concrete examples from your peers. So Lisa?
Hi, everyone. Thanks, Julie. So on the list, you can see there's a number of strategies, like Julie mentioned. But I'm just going to kind of cover 4 of the main elements, and how they are implemented or sort of operationalized really just depends on the setting that they're implemented in, and also sort of the unique strengths and challenges of that particular organization. But for the sake of this webinar, I'll kind of describe some of these 4 in general terms. So the first would be making a referral or a follow-up appointment within 24 to 72 hours. So ensuring that the young person at risk for suicide has a follow-up appointment scheduled promptly after identification is really important to address that high-risk period. And the continuity of care report that Julie referenced says that a week is the recommendation, but really 24 to 72 hours after is ideal. And so what might change from how things might operate for most people today is that outpatient mental health providers would have a way of potentially prioritizing scheduling for these referrals. There might be agreements made between the referring entity and the outpatient mental health provider. And in a really ideal scenario, the group that's making the referral would have the actual ability to make the scheduled appointment from their own site, and that would be if they were integrated. So that's one element. Another element is making a warm handoff. So warm handoffs typically occur in the setting where suicide risk was detected on the left. It involves facilitating a direct introduction between the youth with suicide risk or his or her family and the referral provider. So the introduction could be made by phone or in person. So an example for healthcare would be that a suicidal youth might be in the primary care office, and the provider refers him to an outpatient mental health provider. So during that visit, before the youth leaves, the primary care provider would schedule the follow-up appointment with the mental health provider, and then they would actually put the mental health provider and the patient on the phone together to do an introduction. Or if they're in an integrated care setting, the behavioral health provider might be on site and might be able to actually walk into the exam room, say hello, say, I'm looking forward to seeing you in 2 days. And that could also happen with the parents if it's appropriate instead of the patient. But that's a healthcare example. If the referral provider, meaning the mental health provider, was unavailable to do this, you could sort of introduce an intermediary, like a certified peer specialist or a crisis center, who you would link the patient with that entity or that person, and then they would be linked a second time, finally, to the outpatient mental health provider. So there are some creative ways of working that if you have some challenges. The California Mental Health Services Authority has a website on integrated services, and we can send that link out in a little bit. And they have some protocols on developing warm handoffs. The third key element is transmission of patient information from one setting to another. So instead of just referring an individual with suicide risk to another setting, the referring contact, like the primary care office or the school, obtains permission from the patient to transmit the relevant information about their suicide risk and about the circumstances to the referring provider. So the type of information they might transmit would include the risk assessment information, circumstances around the contact and what may have maybe alerted them to the suicide risk, information about their supports, access to lethal means, anything related to their safety considerations, anything relevant clinical. So HIPAA allows transmitting patient information without the patient's consent if there is a safety concern, but in all cases, we would want to encourage providers to first get permission from the patient to transmit that information. And then the last key element is making follow-up contacts to sort of facilitate and promote follow-through with the referral. So follow-up contacts are sometimes also called caring contacts. These are brief communications with the person at risk made after they leave the settings on the left where they're identified or where the crisis is happening. The contacts might be one time, they might be recurring, and they can involve one-way or two-way communications. And they could be phone calls, postcards, or in some cases where there are resources permitting, it might be an in-person visit. So these contacts are meant to facilitate adherence to the discharge plan or whatever the next steps plan is, and promote a feeling of connectedness to the person at risk by demonstrating a continued interest in their care. And in the hospital example, the contacts could be made by the hospital after the patient is discharged, or in some cases, hospitals have follow-up agreements with crisis centers, and crisis centers take on that role to make follow-up contacts. So those are just the 4 that we were going to cover for the purpose of this webinar. Thanks.
Thanks very much, Lisa. So again, here are the 4 that Lisa just covered, and we're going to be using some real-world examples of some of these and also of a couple other strategies a little bit later on. So before we go on, I wanted to just touch on what is zero suicide versus what is continuity of care, because you've probably been hearing about zero suicide and it can be a little bit confusing as to what is what. So if we look at the diagram that we just had up a little while ago, in healthcare settings, this is continuity of care. But this is zero suicide. So the continuity of care is those stripy arrows, right, that are in between the different settings. Zero suicide is the whole thing, including the identification piece, including the aftercare piece, and it's a whole lot more in addition. So zero suicide is a systems-wide approach to reducing suicide in boundaried healthcare systems with an aspirational goal of zero suicides. It originated from the Henry Ford Health System's Perfect Depression Care Initiative, and I don't want to go too much into it in this webinar because it's a little bit tangential, but it includes things like creating the zero suicide culture, so having a really top-down approach to getting everybody on board, looking at quality improvement initiatives, doing case examination if things have gone wrong, kind of having institutional, thinking about how we can improve for next time rather than placing blame. There are a lot of different elements that go into that culture of zero suicide. And then the competent workforce, identifying and assessing risk level, and using evidence-based care, evidence-based treatments for suicide ideation, behavior, etc. Continuity of care, on the other hand, does not have to be this sort of whole health system-wide approach. It could be one emergency department. It could be one community mental health center. And it also doesn't have to be within healthcare systems. Its principles can be applied to non-healthcare systems. So as GLS grantees, you may be implementing continuity of care in other settings like community settings, and you also may be implementing it in healthcare settings, but not kind of the whole, not all of the zero suicide components. So there's a high need for follow-up post-emergency department and inpatient, and the reason why you may have heard a lot of continuity of care discussion focused on these settings is because these are transitions where a high number of suicides could be prevented. In addition, the concept of continuity of care comes from healthcare medical conditions and such as heart attacks, so you can see why these settings would be a focus. And you can see, why these transitions are really important on your screen, but I won't go too much into that. So to create your approach, you're going to choose your setting. Who is at highest risk? Where are people most likely to fall through the cracks? Where do you have an in? And then you're going to think about your continuity of care strategies. So from that list that we had up a few minutes ago, other strategies that you may come up with, how will you ensure a seamless care transition? How will you train staff in the related protocols? And then you'll pick your partnering strategy. What's important to the system that you plan to work in? What's their culture? As we shared in the last webinar in this series, the partnerships webinar, it's important to understand how they work and what makes them tick in order to make this successful, especially if you're working with mental health or medical providers. You really need to understand the culture and the settings in order to get anywhere. So really briefly, I'm going to look at an example of a hospital setting. The strategy is informal caregiver involvement, and specifically in this case, the medical provider is going to talk about expectations for follow-up care with the patient and with their informal supporters. So what is your partnering strategy? Well, first you have to get the hospital to agree that this is a priority. You need to understand what their priorities are. Maybe because of the Affordable Care Act, they are really interested in lowering emergency department readmissions. Then you can think about what will help them to implement the agreed-on strategy. What can you bring to the table, and what will you ask of them? So in this case, you could train providers on how to do this kind of patient and supporter discussion. You could also develop some patient education materials to help out with this. We do have a handout that we're going to send after the webinar that has a list of the kinds of things that you can do to create continuity of care. It's not a comprehensive list, so definitely add to it, but we will be sending that out afterwards. So just to reiterate the points that I made earlier, we have this up on your screen. What is continuity of care? It's a smooth and effective care transition. It's a concept, not a specific intervention. Screening by itself is not continuity of care. It's continuity of care is what happens after someone screens positive. Emergency departments and psych hospitals are key settings. There's overlap with zero suicide, and you need to work to understand the systems that you're going to partner with. So now I'm going to turn it over to Smitha to introduce our first speaker. And as she's going to do that, I also just wanted to check in with one or two folks on the phone so we make sure we're getting you into the right breakout group. Somebody that has their name listed LAU, can you just chat us in to which breakout you should be in, state or tribal? Thank you.
Great. Thank you, Julie. And I hope that you found that overview of continuity of care useful. I know that there are a lot of moving parts when thinking about continuity of care, so that was just a very brief introduction. And now what we're going to do is we're going to talk about 4 different strategies that a lot of grantees and different programs implement when they're working on continuity of care. So I would like to welcome Janet Kidams-Lilly, who is the Executive Director of the Helpline Center in South Dakota. She is a partner of the South Dakota grant, and she's going to talk us through their work on ED Crisis Center partnerships. Hello, Janet.
Hello.
And also, I wanted to let you know that as we're going to be talking, I'm going to be asking her a few questions. And during our talk, if you all have any questions, you can raise your hand. And if you look on the slide on your left-hand side, you'll see how to raise your hand by choosing the little person with their hand raised. And I will call on you, and to unmute your phone in order to talk, all you have to do is dial *#. So first, Janet, I wanted to welcome you to talking with us on your experience working with ED Crisis Center partnerships. And, we know that Well, let me just go ahead and ask the first question to you. Why do you think it's important to have an emergency department crisis center partnership set up in a program?
Well, as we know, some of the most at-risk individuals for suicide are seen through emergency departments. And so we felt it was important to build that partnership and relationship between the crisis center and the emergency department so they understood the resources that we could better provide for them.
Great. Thank you for that. And I think that, we do know that, those who are most at risk go to the ED, so it is important to have those systems set up in place. So if you could tell us a little bit about a pilot project that you all worked with in your community with the emergency department a few years ago. Can you tell us a little bit more about that and, what materials you used, or did you set up an MOU? Just some more details about that.
Sure. At one of the large health centers in our community, we wanted to establish a closer relationship with that emergency department. So we met with them to identify and let them know about the resource materials that we could provide. Of course, not only the crisis line service that we provide, but also the materials. And at that time, right now, they're available through the SPRC and SAMHSA website. And those are the after an attempt brochures, guide for taking care of yourself and a guide for taking care of a family member after treatment in the emergency department. So we brought those materials with us to meet with the hospital staff and the emergency department and let them look through those materials. They understood right away after looking at the materials the importance that those could have with providing patients when they are discharged from the emergency department. We also provided information about our crisis center services and of course, our phone number and how to reach us 24/7, and asked that they provide that with each patient that was discharged that had been admitted with some type of suicidal ideation.
Great. And when setting up this relationship with the emergency department, did you create a memorandum of understanding?
At that time, we did not. As we're looking to further our relationship with them through this grant process, we will have a formal MOU identified with them.
Okay, great. And with the new grant that you all received with Cohort 9, how do you plan on expanding the relationship with the emergency department?
Sure. We've already had meetings with them to expand the service by providing further training for their staff. We will be providing the online cognito training for emergency department staff, and we'll also be providing means restriction training for their staff. Once they have identified a patient in the emergency department that is at risk for suicide or presents with suicidal ideation, and they are not being admitted to the facility, the patient will be offered to participate in the follow-up support program. They will sign a consent and release form, and then that patient's discharge information and any safety planning that was done with them will be faxed to our crisis center, and then we will follow up with that patient by calling them within 24 hours to reassess how they're doing, and then also to talk with them about the discharge plans that were made at the time they were discharged, what appointments those were, did they have any barriers in reaching those appointments, do they need assistance, is there some kind of resources we can also connect them with, and that will be the initial phone call within 24 hours, but then we will also have additional follow-up phone calls that will be scheduled over the next 4 weeks, and that will be based upon their level of crisis and support that we feel that they need. So that phone call, the next phone call may happen a day later or it may happen a week later.
That sounds great. One last kind of wrap-up question. When creating this relationship with the emergency department, were there any challenges or lessons learned that you want to share with the group?
Sure. I think, of course, it's all about relationships, and
On my board of directors, we're a nonprofit agency. I had a board member from the health or the hospital system. They did not work specifically in the emergency department. However, they could put me in contact with the head of the emergency department, and so that really made that first conversation that I had with the director of the emergency department go very smoothly, because I was being recommended by another staff through the health system.
I think that's a great relationship, and it shows, the hospital that if somebody on the hospital is sitting on the board of this organization, it just gives it a little bit more credibility. So that's great. I wanted to quickly open it up to the floor just for a minute or two. If anybody has any questions, you can unmute by pressing *#, or you can raise your hand, again, using the little icon on the top, and I will call on you. And in addition, if you don't have any questions right now, we can revisit these topics definitely during the discussion portion of the webinar. All right. Well, seeing no questions right now, I wanted to thank you, Janet, for sharing your pilot project and the plans that South Dakota is going to be working on with expanding their relationship with emergency departments and crisis centers.
You're very welcome.
So now we are going to move on to our next topic, which is going to be using informal caregivers. And so I wanted to welcome Roxanna Coleman, who's the training coordinator at the Confederated Salish and Kootenai Tribes. Hi, Roxanna.
Hi, how are you?
I'm good. How are you?
Good.
Good. So thank you also for joining us and sharing some of your experiences on working with informal caregivers. And again, just to remind everybody that if you have any questions, you can raise your hand. Again, on the slide, you'll see the icon with the little hand raised icon. So feel free to click on that, and also to unmute your phone. All you have to do is press *#, because right now all of you are muted to reduce the background noise. So, Roxanna, I just wanted to start off just asking you the general question of, can you explain who informal caregivers are in general?
Well, I think in our case, our informal caregivers are actually our community. I started back in this program in 2007, and we started building relationships. I mean, I loved what Janet said earlier from South Dakota, that it really is about relationships. None of us can do any of this on our own. I think you do need to have the community behind you, and kind of the reason I wanted to talk about this today is we've kind of missed the mark, and I think it's probably across the board. When we know that someone's been identified at risk of suicide, or there's been a suicide that's been completed, my husband and I both do the gatekeeper training, the assist, the newer version, and we kind of miss the ball with the survivors. When there's a suicide in the community, they're left out there pretty alone. And I liked what Janet had talked about earlier. It's like doing some follow-up with that family, because they can ultimately end up being in that same river of suicide if there's not some help there for them. So since 2007, I've kind of been thinking about what can be done without breaching confidentiality for the families once a suicide occurs within that unit. And what we're thinking about doing is we have a partnership that's been going since 2007. Actually, it started with 7 people, and now we're like 46. It's been up to 57 people in the community, and it's a mix of caregivers, clergy, law enforcement, just local business owners. In Montana, as you know, we are in first place with Wyoming for completed suicides. Resources are not easily accessed. They're not always available when you need them. And our community is certainly talking about that and making that a priority. Health and wellness, through our tribal council very recently, has made that a #1 priority in this community. So where we want to be in this program is we want to use the community, our coalition. It's called Partners in Suicide Prevention and Intervention. We want to use the community to help us to build care packages that can be distributed either through the emergency department, it was talked about before, or through law enforcement, or through the, I like the peer specialist term that was just mentioned. That just is cool. If we can somehow get care packages out there to these families, we already have people in the community, for, Pizza Hut, Subway, that are donating certificates, as well as we have brochures that have information on access to lethal means, help numbers, certainly the suicide lifeline number. We have lighted wristbands that glow in the dark, which are kind of cool. So we're thinking about different things that we can put into a care package that lets that family know that they're truly not alone. It's one thing to say, we care. It's another thing to show that you care. And when that comes from a community of people you don't know, that's a very, that's a really strong linkage. And I thought about people who I know whose families that there's been a suicide. So we've kind of done a little questioning. It's like, what's most helpful when you're going through crises or when there's a loss? What is it that's most helpful? It always comes back to somebody to show they care.
Great. Thank you. What I wanted to ask also is, with your informal caregivers, and you said that you are a trainer for ASSIST, and I know that that's the training that you all use for your informal caregivers and gatekeepers. You had mentioned to me earlier that you have a new sheriff in the office, and you're going to be collaborating with their sheriff's office and sharing with them who the gatekeepers are. Can you tell us a little bit more about that?
Yeah, we was thinking, we're going to have to talk about this because, again, it comes down to confidentiality, and we certainly don't want to breach anybody's confidential information, but we have kind of had a couple conversations, and he's very open to what can we do to collaborate and enhance the work that we're both trying to do, which is, protecting, safeguarding our community and keeping people healthy and alive. So I think when I was listening to Janet earlier, I think probably a MOA with both the Sheriff's Department and the emergency room would be good partners to have on board. What I was saying earlier, what I had talked about is I've taken people to the emergency room. Sometimes people just don't know who to call, and because our program is very visible, we have our numbers out there. But I can remember going into an emergency room with a gal. There was no alcohol involved, there was no drugs, but she was struggling really strongly with suicide ideation. I waited with her for 5 hours, and I was so frustrated because I know we have limited resources, but 5 hours is truly unacceptable before someone could get there to even do an assessment. So it kind of shows that we have limited resources. And so what I was talking with our new sheriff that is going to be taking office a minute after December 31st, he kind of has a really compassionate heart too. And we're really going to be putting a focus on how can we utilize some of our people that are trained in ASSIST. They're caregivers, and I think it would give them an opportunity to really take an active part in the community. We've got to work out some of the little details, like how we can get these care packages out there so it is not only law enforcement, it could maybe be this a certified peer specialist, a gatekeeper, a certified gatekeeper, to let families know that they're not alone, and if they need help, we'll try to get them connected to those caregivers. We just need a lot more mental health people that are more responsive. And I know I'm not trying to say anything bad about mental health, but sometimes it's just so much, the problem's so big that there's not enough resources for the demand. So
Right.
kind of where we're at.
And I know that one of the things that you mentioned to me when we were talking a couple of days ago, what is something that I really liked, where you said that informal caregivers are people who want to do this and not those that have to do this. A lot of times we train, people in the field who this is part of their job, and I liked how you said that informal caregivers are those who really just straight up have the passion for it. So I wanted to thank you for your time today. And again, we will be breaking out into groups. And if you have further questions for Roxanna, you can ask her during that time. So thank you, Roxanna, for joining us today.
Thank you.
And now we're going to move on, and you all get to listen to me a little bit more. Again, this is Smita, a prevention specialist at SPRC. And I'm going to briefly, for just a couple of minutes, talk about telemental health and how it can be beneficial to getting people the services that they need. And I'm going to be just pointing out a few examples from a couple of different grantees from other cohorts, and that we know that many communities, especially those in rural and frontier areas, have a shortage of mental health providers. So some programs and grantees have set up telemental health services to be able to give those without access to face-to-face appointments. They're able to get contact and care with mental health providers using technology. And I'm just going to point out a couple of different examples. Many of you might be familiar with the Carleton County, Minnesota grantee. And a lot of Minnesota is rural. And so what they were able to do was use telemental health services to offer appointments during school. They worked with a couple of different schools in the county, and students were able to receive counseling from their mental health professional via video technology. They set up video technology within the health center at the school, and that way the student did not have to leave the school health center. It also, a lot of times people are discouraged to seek out mental health services because they don't want others to see that they're going to a therapist or a psychiatrist. And so this way, the mental health telemental health technology was offered just in the health center, so other students may not have known why the person was accessing those. And again, they were able to do that during school so that the student didn't have to travel, didn't have to wait to go after school if they were in crisis. Another grantee that I wanted to mention was Hawaii, and they used telemental health to help reintegrate people from inpatient services back into the rural community. So those clients who were admitted for inpatient services, once they were reintegrating back to their rural community, which may have been miles away from the hospital they were staying at, the appointments continued over telehealth or the telehealth video technology, so that there was that continuity of care of talking to the same person that they had already built a relationship while they were in the inpatient services. And lastly, I wanted to share a success story from New Mexico. And New Mexico has they've set up a lot of different school-based health centers. And one day there was a 12th grade student who was referred by a teacher to the school-based health center who was in crisis. However, the behavioral health provider for that area was at another school about 30 miles away and was not able to get to the school that the student was in until the next day. So the school-based health center was able to connect the student with the provider via telehealth equipment, so that that person in crisis was able to see somebody even though the provider was over 30 miles away, and then was able to follow up with an in-person appointment the next day and for several visits afterwards. And of course, they were happy to report that the student is continuing to do well and was on schedule to graduate on time. So that was just a success story of an actual person using the telemental health services. So again, we can talk about this further in the discussion groups, and also, of course, any of these topics you can talk about with your prevention specialist in a little bit more detail. And I'm going to pass it on over to Julie for our last strategy. Julie?
Thank you, Smitha. I want to introduce Julie Geddes from the Oklahoma Department of Mental Health and Substance Abuse Services. And Julie's going to tell us a little bit about a tool that they created in Oklahoma to help with continuity of care, which is a third-party referral form. So welcome, Julie. Can you tell us a little bit about what prompted you to create the tool and maybe what some of the problems were that you were trying to overcome?
Sure. When a parent takes a child to a provider, often the child gets to the provider and says, there's nothing wrong with me, I'm not crazy, I'm not suicidal, and they're very frightened and they don't want to go. Also, our mental health providers were telling us that it would be very helpful if the schools, when they sent somebody to treatment, would provide a third-party reporting tool so that they would know what the school was seeing in the kids. So what we did was we got together with the schools and with a couple of mental health providers to create a form that would be easy for the schools to fill out to help the kids get the kind of care and make sure they have that continual care and people know kind of where that child is as far as in the spectrum of getting care. Let me go on?
Yeah, sorry, great. We were just trying to hit on the tech end to make the form larger so that folks could see it. Sorry. So, that's okay. So can you say a little bit about how the tool works? You said that the teacher would fill it out.
Sure. What happens is that, the teacher or counselor, it depends, sometimes teachers will bring the child to the counselor's office and the counselor and teacher may fill it out together. So what happens is they will go in and they will fill in the blanks, basically what has happened, what the school saw, what's the name of the child, and what happened, what have you been seeing, what's the history look like, what they feel like how this child is feeling. Are they lonely, or do they seem to have some really interesting or completely different habits that they haven't seen before? And then they are given 3 resources to send with the parents, so that there's 3 resources that are filled out on the paper that are local for them, with their phone number and their address, their hours of operation, so they will have an idea of where they could possibly take their child. Then the parent, it is handed to the parent, but they make 2 copies. And the parent, some of the schools ask the parents to sign one of the copies immediately so that they can put it in the student's file. Anyway, and then the parent then has something to take to the provider that shows what the school is seeing. And then when they're done, it doesn't have to say they've received treatment, but they will take the document in, and the the provider who's seeing this child or has seen this child, well, they will sign it, and then they will take it back to school. They don't always get them back, but at least some of them are coming back, some of them aren't coming back, but at least it gives the parents a tool, and it also gives some way of clarifying to the parent and making sure that they are documenting at the school level.
That's great. And how's it working so far? What have you been seeing?
Well, the mental health providers are very pleased because what happens is, like I said earlier, many of the parents, they go to take their child and, on the way or even after they get there, the child will try to talk their way out of it because they're afraid of what's going to happen to them. The parents like it. The schools are very appreciative of it. One of the issues that we were working with schools is the schools wanted to make sure that this was signed and there was a treatment involved, et cetera, before they'd allow the students to be back in school. And we told them that it was the safest place for them to actually be in school, so they really shouldn't do that. They should really allow the child to be in school, but at least this way was one way of hopefully getting the child to some services.
That's great. And if somebody wanted to create this, do you have any tips for them or any other unexpected problems? You were just sharing one. I don't know if you have any others.
Well, I think it's helpful as we've done this now for probably 12 months, I think it's helpful that if you can get the parent to sign before they leave. Initially, the schools were just giving it out to the parent, and then they would, the counselor would sign or the school representative would sign it. But now the schools are asking them to have it signed ahead of time. This form is going to be used, I think, by other entities as well. We had a meeting with some people from the crisis team, mobilized crisis team, and they said, that'd be helpful for them, for anybody that, had to call 911 or for the police department to verify what is happening. Because sometimes when somebody calls from 911, it's like immediately they need someone to find out what's going on, and they can't because maybe the person who they've called on is in life or death situation, so you don't always know what happens. So even our law enforcement and our crisis teams are really appreciative of this tool and want to use, and we're talking about developing one specifically to give to law enforcement or to first responders.
That's great. Yeah, when we had talked previously, you mentioned, if there's a crisis intervention team, maybe they have to stabilize a suicidal person, but whoever called 911 may not still be there to kind of fill out what were the behaviors that they saw that they were concerned about. And same with the teacher. That way, I think you had said that the teacher, that way they can go back to teaching class and they don't necessarily, need to be there to talk to the parents. So that's really helpful.
Sure.
Well, thank you so much, Julie. Did you want to add a last thought before we open it up for questions?
I think it's a wonderful idea. It's been very productive for us. So, and it lets everybody kind of know where that child is on the spectrum and how to check back with them and, kind of things like that. So.
Great. So does anybody have a question for Julie? And if you do have a question, as we said before, go ahead and raise your hand like it shows on the little screen there, and then we'll call on you. So I realize this is a lot of people talking, throwing information out at you guys, but we're going to have a chance for some smaller group discussion in just a moment. So thank you very much, Julie. That was really helpful, and I'm excited to hear more about how that goes in the future.
Thank you.
So we're going to transition to our breakout groups, and this is a little bit different than how you may have done it before if you've done breakout groups with us before. What we're going to do is, we're going to have